Warm welcome to today's ISQua webinar on avoiding the 100% satisfaction trap, a model for developing meaningful patient experience surveys. This session will challenge the view that the high patient satisfaction scores provide sufficient information about the patient experience. And our presenter today, Dr. Sebastian Devkaran, who is a leader in quality, accreditation, and patient experience in the Middle East, Africa region, and currently holds this position at Cleveland Clinical Abu Dhabi. She serves on various regulatory committees and leadership societies in the Middle East. Being a lifelong learner, Sebastian has a PhD from Edinburgh Business School, and she was a master in healthcare management from the Royal College of Surgeons in Ireland. She also serves as an associate lecturer with the university. Sebastian acquired her clinical degree in physical therapy from South Africa and received recognition as a certified professional in healthcare quality from Healthcare Quality Certification Board based in Washington, D.C. She is a fellow of the American College of Healthcare Executives and a fellow of ISQua. In addition to her full-time role in Cleveland Clinic, Abu Dhabi, Dr. Devkaran is also an international consultant with Joint Commission International. Sebastian regularly speaks at international conferences and has published research papers on healthcare quality and patient experience. With a passion to reduce the knowledge gap in healthcare quality and patient experience internationally, Dr. Devkaran continues to pursue research in these areas. Just to remind you that today's presentation will take approximately 45 minutes, and we will leave 15 minutes at the end for any questions that you may have. Please type your questions into the chat box or question box provided, and they will be posted to Dr. Devkaran at the end of the session. Please note that we will be using polls during the session, and we would appreciate your active participation. Now, sit back and relax and enjoy the presentation. Over to you, Dr. Devkaran.
Well, hello and welcome. It gives me great pleasure today to speak to you about a topic that I am extremely passionate about. I'd like to share with you today how we can develop meaningful patient experience surveys. And so our objectives is, I'd like to start by creating some sort of context. Talk about what are the fundamental considerations in developing a patient experience survey. And then, of course, share with you some innovative ways to measure the hard data when we're measuring soft stuff. And then, of course, we wouldn't be complete without discussing strategies on how we can make the most out of that data. And so to start, things were quite simple when I was a kid. Kids played games. Anyone could make a call from anywhere. Almost every doctor had one of these. I'm sure you remember that. And then patients could go here for healthcare. That was pretty limited. But things are a little different now. Kids play games, but on computers and iPads. Anyone can make a call from anywhere. And then, of course, almost every doctor has one of these. In fact, patients could now go to their devices for healthcare. So you see, there's an emerging model of healthcare. The E stands for the emerging model. The M stands for the population that we're caring for. And then if we look at the 4 C's, we can have care anywhere, care in teams, care by large data sets, and then also the future will be care by machines, and it's already happening. And so, when we think about patient experience, we need to think about the evolution. You see, patient satisfaction was what we used to measure, and some organizations still do, but it's really a very subjective evaluation of how the patient has received the care. And then we thought, oh, well, we could fix this by adding customer service programs into our remit of caring for our patients. And putting on a happy face didn't really last very long. And then emerged patient experience, where we started thinking about, well, what exactly is the objective evaluation, what was done to the patient during the continuum of care? And then we realized, yes, while we can involve patients into the patient experience and improve that, we need to combine patient experience and engage patients so that we can in fact have improved outcomes. And so that's the sweet spot that I want to talk to you about today. Just very quickly, providing care that is respectful and responsive to individual patient preferences, needs and values, and ensure that patient values guide our clinical decisions. That is the definition of patient-centered care. And essentially, there are 4 attributes. Looking at the patient as a whole, thinking about the 3 C's, coordination, communication, and collaboration. And then looking at the ready accessibility in terms of patient support and patient empowerment. And so, when we move forward in terms of patient experience, we're thinking about the patient as a person, not a disease, not a diagnosis, or any sort of other adjective. And to illustrate this further, I'd like to share with you a quick video.
I had heard what no woman ever wants to hear. You have breast cancer. And I remember sitting up and going, what did you just say? And she said, yeah, you have breast cancer. It's confirmed. I walked out of the breast center and I stood in the lobby going, oh my God, what the hell just happened? I had a very uncommon occurrence when your pancreas explodes, as mine did. It felt like somebody cut me wide open and put a record fracture in my and that happened over minutes. I went from living my life to about 16th community over the 4 months of hospitalization. I had 20 operations or major procedures. My wife literally came out my bedside every day because I didn't know if it would be lasting. I was driving home, I didn't feel right. My car drove off and dropped about 35 feet. I had a seizure probably bad this time. Ankle, a lot of things were broken. I spent about 3.5 weeks unconscious. I had almost none of my major organs working. And yet I was hearing many conversations reassured. My family had had 2 sessions about end-of-life care. I had thought how interesting it was that I was watching myself die. When I initially was diagnosed, how it was presented to me, other than maybe a softer touch, she scared me. It scared me sick to begin with, but she knew I was alone. All I was worried about was living. I wanted to dance in my daughter's wedding. I wanted to hold my grandchildren to stay only about 2 feet up and able to eat. It was very difficult to do almost anything. So to be reduced to somebody who's essentially dependent on others for almost every facet of their criteria is really difficult. It's sort of a helpless feeling, especially when your kids are helpless because you really rely on them for everything. So having that one-on-one communication is really waiting there and you're laying in that bed all day. All you want is 5 or 10 minutes. That's it. So during my ICU stay, I lost 50 pounds. Every time that the nurses and others came to turn me, to change the sheets, to clean me up, it felt as if my hips and my shoulders were coming out of joint to make your head completely lost your ability to care for yourself. 5% forward. And with it, I didn't take any left. kind to the person passing, walking a little slower than you. You don't really know what they're going through. A lot of people tell me, oh, I know how I feel, you know, until you become a patient. No, you don't. It's a sense that there's their hand or all those things that I'm very superior. When I feel like I'm at the end of my rope sometimes during a busy day, and I try to put myself back in my bed. And then when I see somebody who might be angry, might be frustrated, I remind myself what that feels like to be there. And then it makes sense.
Sorry, Dr. Sebastian, the video audio wasn't very clear, so we had a number of participants saying that they couldn't hear. So maybe you can reiterate the message that, and we can share the link separately with the participants so they can view the video separately. But maybe for this session, the broadband speed wasn't very good, so we'll maybe not use it or just share the link for the participants to view.
Sure. Thank you, Juliana. And so I apologize for the sound, the difficulty with the sound of the video, but essentially you could see that the initial people that were talking to you were actually patients. But as the video progressed, you could see that they were in fact not just patients, they were actually healthcare providers. And these healthcare providers, being in the shoes of a patient, having experienced what patients had gone through with their own healthcare issues, were able to be more empathetic, were able to change the way they perceived what patients needed because they could relate somehow to their eventual needs. And so the idea is, the powerful message behind that video is that you don't have to be a patient to be an excellent provider, because we have so much of information available from our patients to understand what care they in fact need and how the care should be delivered. And so I wanted to show you that video just to tell you that patient experience in fact is difficult to measure. But we have to concede that the patient's perception is your reality. So this was a cover page of JAMA drawn by a 7-year-old who had visited a pediatrician. And look at her perception of her pediatrician. He's scowled over his computer, of course taking notes. This is the patient, and then this is the nurse. But it's very, very interesting in how patients perceive us. And so we need to start making changes, but how? Well, it makes sense that we start with the patient. And think about, when we're looking at our patient experience strategy and we're looking at creating surveys, we need to first understand what matters most to our patients. And so, again, if you saw in the video, the people were talking about the type of suffering that they had to endure, the suffering that they had to endure in terms of being given a diagnosis, then suffering through the treatment. You know, the physician talked about every time that he turned, he felt as if his joints were being ripped out of his sockets, and then suffering from the defects in the care that we deliver, the waiting times, the lack of handover communication, the repetitive tests, not knowing what's going to happen next. And so studies have looked at what are the fundamental factors that influence patients in terms of patient experience and patient satisfaction. Nurse empathy is one, physician empathy is another. The ability to keep our patients informed, of course, the outcome of the procedure, things around the environment, the cleanliness of the room, the way the room appears, the quiet environment, administrative simplicity, when we're looking at when billing, getting information about our care as well. And so once you understand what matters most to patients, you then need to start as an organization and say, we need to define our patient experience definition. What is the definition? And so here's an example. One is create a beyond exceptional experience across the continuum of care where patients, our families, our colleagues feel part of the organization's family. And so that's very important. If you start thinking about a patient as a family member, that automatically triggers a different way of treating them. And then, third, before you start measuring patient experience, you need to think, what culture are you, in fact, what culture do you belong to, and what is the way that you're going to implement this particular survey tool or this measurement tool? And so you heard commonly by Peter Drucker that culture eats strategy for breakfast. So yes, strategy is the intention, culture is the habit. And it's hard to change culture, hard to change habits. So the best way is establishing it as an organizational priority. That message is powerful. Organizations around the world are including patient experience as their #1 priority. Quality is second, and of course cost is third. And so one of the organizations that I work with, patient experience is a #1 priority. Caregiver engagement is #2 because you cannot get a good patient experience without engaging our caregivers. And then thirdly, quality and patient safety is another fundamental component. And then cost, finance, because we want to be sustainable organizations for the future. So once your leadership establishes a true north, we need to cascade that priority, cascade that focus and that goal. So I always use the term think globally, so think as an organization, think as an enterprise, and then act locally. And so here's an example. This is an enterprise metric for patient experience, and they're using the likelihood to recommend index. Then we have at the hospital level, the likelihood to recommend for the hospital. And then we cascade that information to goals. And one example here is the critical care unit, where in terms of patient experience, they want to improve the score, not of likelihood to recommend, but improve the score of how staff introduce themselves, using a specific tool called a DET. And so why did they choose that goal? Because they found there was a strong correlation between the likelihood to recommend and the use of ADET. And so at the individual level, we're saying, we want to use ADET 100% of the time when we're greeting patients. And so that's how you're changing the culture of the organization. And then once you've started as a priority, you need to think about your measurement strategy. And so here's the part you're waiting for. What do we do when we're measuring? We know technology casts a wider net. You can reach more people using technology. But then you need to understand there are multiple ways you can measure patient experience. And from those that are more generalizable, like surveys, that are quite descriptive, to those that are less generalizable, but they're very, very descriptive. They tell you exactly what happened during that encounter, what went wrong. And so here's the big idea, and you'll see this throughout the presentation, and I'll be sharing some big ideas with you, that when you have more than one data source, you're actually very, very prone then to triangulating that data and having really, really accurate information. And so you could use in-depth interviews, and we've done that. Focus groups are excellent too. But again, you cannot generalize it to the greater population, but you can particularly understand the experience of the patient. And so we know that patient experience spans the entire continuum of care. Even between care encounters, that composes of the patient experience. So remember also, it's not the entire patient journey. it's also the mini journeys throughout the patient's journey. So their little journey that they have when they're going to surgery, from the holding area until the time they reach the theater, until the time they get to the recovery area, that's a mini journey. And that is a very, very important component of their experience. And so when we're thinking about it, we say, okay, we selected our measurement tool, but what do we have to, when do we want to measure? Think about those mini journeys. Do you want to measure at the time of admission? Do you want to measure after the patient has left the organization, after they've had their full experience? Or do you want to do it at the point of care? So they go into the lab, they receive the care, and then they have a little tablet or some sort of application that asks you to rate the service. Or you could do continuous monitoring feedback strategies, again through applications. But here's the big idea. You need to collect feedback that is as close to the encounter as possible in order for it to be more accurate or more positive. And so here's a quick poll. Juliana, will you help assist me with this poll, please?
No problem at
So the
all.
question is, thank you. What methods are you using to measure patient experience? And
the
so
options.
one is not measuring. Yes.
And the options are not measuring patient experience. Number 2, using a paper-based tool. Number 3, using an electronic survey tool. And number 4, using a combination of tools such as calls, survey, focus groups, etc. So the poll is open for voting, and we can see that our audience is actually voting. We have 60% of our participants that have already casted their votes, so we'll give them a couple of more seconds before we display the results on the screen. We can see some of the results are coming into the chat box. Please do use your keyboard to cast the votes on the screen. So choose one of the options on the screen rather than putting it into the chat box. The data is being collected there instantly, and we will display the results now. So I am sharing the results on the screen, and for those ones who can't see it, 19% of our participants not measuring patient experience, 33% still using a paper-based tool, 15% are using an electronic survey tool, and 33% using a combination of tools such as call, survey, and focus groups. Now, over to you, Dr. Devkaran.
Thank you very much, Juliana. That's very, very interesting that some of you are still measuring patient satisfaction or not measuring patient experience at all. And then it's nice to hear that you're using a combination of tools, because that really is a best practice. So I'm going to walk you through a few steps of how to design your own survey. Because while we can use surveys that are out there in the public domain, it's very difficult to tailor to your patient population, especially if you have a multicultural population, as well as a different socioeconomic group that you're looking at, or maybe you're providing a very specialized sort of care services or scope of services. So the first thing, which will be pretty intuitive, is actually looking at the literature review. And so some of the things that you can look at are white papers, some authoritative sources, and then peer-reviewed papers as well. And then once you start understanding in the literature review what really matters, what are the fundamental factors, as I shared with you earlier, you start developing a construct. And then below, within the construct, are the survey questions. And then once you test, you need to test the construct, and you need to test the survey questions using content validity checks, which means you're really trying to see if you've captured all of the domains, if the question is actually measuring what it's intending to measure, and the survey is measuring what it intends to measure, and that in fact that there is no discrepancies in understanding when you're administering the tool. And so after you've done that content validity check, you would need to pilot it on a small group of patients. And the reason being is that you need to then, once you've got that data from the small group of patients, you need to check the internal consistency and reliability of the survey. And one of the methods is using the statistical tool called Cronbach's alpha. And this is really to ensure that, you know, you have the questions within the construct, that it's in fact reliable, that it's going to give you the valid data and reliable information. Based on your results, you will find that if you modify some of the questions, your Cronbach's alpha is going to increase, giving you a better internal consistency, better reliability. And so from that, then you start measuring your data collection tool. So now that you've got the content of the questions, you've got the constructs, you can build your data collection tool. So for those of us that are using IT applications, it is quite a lengthy process. We have to build in the users. We have to think about the different departments and how we can, you know, actually drill down to those departments and whether all the questions are relevant to those particular units. And then think about how often you're going to administer it, how you're going to talk to the patients about it, how you're going to reach out to them. Paper forms are also challenging because you need to think about how it would appear to the patient, that the wording of the questions are correct, the appearance is correct as well. But even if you're doing telephonic interviews or telephonic surveys, you need to develop a script, because whoever is going to administer that survey via the telephone needs to be quite consistent in the way they ask the question. So they cannot ask leading questions. They cannot prompt patients to get the answers that they want. So there's a fair amount of work to be done in actually building the data collection tool. And once you decide on the data collection tool, you then need to think about what is your sample size. How many patients are you going to administer the survey in order to get statistically valid data? And so when you go out to the units and you say your patient experience score is 80%, they're going to ask, well, how many people responded? And so defining the sample size, there are a number of statistical tools. One that I use is Sloven's formula, which is very, very simple to calculate. And then finally, you want to administer the survey. And like we discussed earlier, the timing of the survey, how long it's going to take. What is the right environment that you want to administer the survey? Do you want to administer it before they see the physician or after they see the physician? When they're in pain or when they're not in pain, close to discharge or after discharge. And then the analysis and sharing of results is very fundamental. And we'll talk a lot about that later. So I know those are many steps, so I've just created an acronym for designing surveys, which is called the COMPASS method. So C stands for conceptualizing the problem, O stands for thinking about the operationalizing the concepts, the dimensions, the domains, the questions, M about the methodology, you know, what is the administration method that you want to use? What are the scales you want to use? Is it going to be a 5-point scale? Is it going to be a 6-point scale with a middle, some sort of a middle ground, or not applicable? You need to think about that. And then piloting is very, very fundamental. It's imperative to pilot because once you start, you know, unleashing your survey tool to the rest of the organization, it's very difficult to explain to your leadership that, you know, no, actually we didn't know that before we administered the survey. Now you've got tons of data which may not even be reliable, valid, or consistent. And then again, looking after the pilot study at reliability, validity, you know, looking at if you want to add, delete, looking whether there are meaningful differences in scores, and then finalizing your particular survey instruments format. And then let's refine the concepts, you know, further, and then looking at how we improve that survey and finally administering that survey, and then testing out our assumptions. And so most people, when they're designing the survey tool, it's all about the questions. You know, what questions should we add? What questions are not relevant? But they don't think about at the back end that later on, when you're trying to understand the data, you haven't added enough questions about the patients themselves. So this is what I call patient profiling. You know, trying to understand what is your patient demographic. Maybe you know that in terms of your census, but you may not be able to think about how different patients perceive their care. And you can do that correlation if you include questions on the patient population itself. So some things about their self-reported health. Do they have a poorer experience if they are in poorer health? Their education level, nationalities have different experiences because we need to think about their cultural tendencies as well. Language, age group. So studies that I've done previously, we found that an older age group had a more positive experience. That's because they had less consumer expectations because of their historical experiences in the Middle East. Marital status, we found females were more discerning than males. No surprise there. And then length of stay. The longer the patient stayed in the organization from the study that I had done, the better their experience because they got to actually experience entire continuum of care. That was for my patient population. The literature said differently. So this is another reason why you really want to understand what your population needs are. And so when we're looking at the different care domains, the care domains are your overall constructs. And so the big ones we talked about was care from doctors, care from nurses, looking at those here, and then the way we manage our operations and procedures. Cleanliness is a very big construct for patients in general, and then respect and dignity. Coordination of care is important too. Food, and that depends on your environment and your patient population, but that was a very important factor for us as well. Including some others which you may find in the literature. You may find them within Picker Institute HCAPS, which is used in the United States. And so when we're looking at designing a survey, the appearance of the survey, the formatting of it is very important. So we knew that we'd have a mixture of patients with different literacy levels, languages as well. So you can see in this example, we've translated it into Arabic. We used a FACES scale as well to help them decide which was the positive and which was negative. This is very useful, especially when you have negatively worded questions and the scales reverse. Think about that. Patients may be saying, oh, 1 to 5, it's always a 5, but your question may be somewhat reversely worded. And so looking at the constructs, pain management within that, we had, did the doctors explain the pain? Did the nurses explain the pain? And then how was it well controlled? And all of these questions had to correlate to pain management in the hospital. And so you can also very cleverly in your survey tool ask patients what matters to them, what's important to them, and they can write it in terms of a 5-point scale and tick the boxes and you can do the analysis. Or you can actually get them to rank it in order of importance, which is what we did. And it was most illuminating because what we think is most important to patients are not always the case. And then 7, looking at your data. Okay, you've administered the survey, you followed the steps, and now you have data and you're going to present it. This is the common way data is presented. And if you look at it, a nurse on the unit is not going to understand what a 4.2 is. Is that good or is that bad? And where does she fit? Where does the critical unit fit into this whole graphical presentation? And so, really, if you can't explain it simply to your caregivers or to the nurses on the unit or the providers, you don't understand it well enough, and neither are they. And so, when we're thinking about data, there's a temptation to form premature theories upon insufficient data. And so the nurse on the unit will say, oh, we're doing very well, but in fact, we may not be. And so the other important part, on the contrary, is that hiding within the mounds of data that we collect is knowledge that we could change the life of a patient or we would change the world. And so when we're presenting data, it's very important to think global again. Think global. Think at the organizational level. But make sure that your patient experience data can drill down to the unit. So add questions about where did the patient receive that care? What was the date of their care? What was the admission period? And then, so that you're able to go down to, for instance, to the lab, to our front office, to our admission staff, to the physician. And so one of the tools that we use is a data analytics tool that allows us to do this drill down. So we can look at it globally as an organization, but we can also drill down to the particular site, to the unit, to the actual group of providers, even to the date and the time. So now that you are smart enough to collect the data, to get the data to that level, what's next? How can you make those improvements? You understand what's wrong, but now you need to make it right. And so this is the integrated patient experience structure. You must have some sort of a forum in which to make sure the changes are being made. And it's recommended that you have a patient experience steering committee at the board level, because that's really the decision-making body. And then have a patient experience team, if you could, have a leadership team. If not, then you can have a task force or a group of people who are interested in it. And then one of the things that I found really useful is having a patient and family advisory committee. Now, what is that? For some of us that's new to the whole concept of patient experience, the patient and family advisory committee is really that fundamental advisory resource that will tell you, how can we improve the facility? What programs can we develop that will be meaningful, not to caregivers, but to our patients? And then they can actually communicate that throughout the organization as well. They are the group that will help you in implementing the changes. Very, very important. And then you can have service line patient experience forums as well. So like I said, within the laboratory, within the critical care unit, within your medical ward, you can have those patient experience forums. But remember, even if you have a leader or a patient service manager, you need to have physician leadership and nurse leadership as well, championing the cause. And so here's the big idea: nothing about me without me. And sorry, so let me just go back to that particular slide. Juliana, I think we have another poll for this slide.
So the next poll is now launched, so you should be able to see it on your screen. And the question of the poll stands as follows: what is the hardest thing about being a family member in the ICU? Is it the noise at number 1, the lights at number 2, the lack of privacy at number 3, seeing suffering all around you at number 4, or the doors and waiting room at number 5? So you can choose between the number of options that are available there, and we can see that our participants have started voting. The votes are divided between a number of options, so we will just give a couple of seconds before we display the final results. 60% of our participants have voted, so we'll just give an opportunity to those whose broadband connection maybe is not as fast. Okay, so we are going to close the poll and display the results. And for those who are not able to see the results on their screens, the results are as follows. 21% voted for the noise, 4% for the lights, 25% for the lack of privacy, 39% voted for seeing suffering all around you, and 11% for the doors and the waiting room. I'll hand it over to you, Dr. Devkaran.
Yes, and so that's very, very interesting. To be honest, that was my perception too. And so, in fact, if we hadn't asked our patients, we would have not realized that it was the doors and the waiting room that were their concerns. So look at the doors. I mean, what messages this is give this to you as a patient? Clearly it says, you're not welcome. And so look at the waiting room. The waiting room. So this is an example of one of the organization's waiting rooms, and this was very difficult for patients to have the level of privacy to be able to talk, particularly if they were bereaved or grieving or concerned about their loved ones. And so using the patient family advisory committee helped changed these environments so that we became, so that the organization had become a better organization for patients. And so some of the changes that were recommended in changing the waiting room were nothing that caregivers would have contemplated. For example, they wanted to have an area with a desk that was semi-private where they could go and get some work done while they were caring for their loved one. They wanted to have little cubicles, a vending machine where they could have some refreshments while they're waiting. So these are some of the things that are very, very, very illustrative of how we should involve patients in our patient experience strategies. So tell me and I forget, teach me and I remember, involve me and I learn. So this is on the caregiver side and on the patient side. Involve them in your patient experience strategies. And we can use various technologies to involve them. We can have interactive patient care with some sort of web-based tools. We can do rounding with patients. So that's when nurses and physicians, when they come to round, can actually invite family members and patients to participate in the round just for their particular care. The electronic medical record is another way. There's, Open Notes. Open Notes is one software where patients can have access to their own electronic record, and that's outside of the hospital environment. So there are a number of technologies that you can use to engage the patient. But again, don't become a slave to technology. Don't let technology cloud your vision. Because really, if you look at patient experience, we started off with the triple aim of improving patient experience, improving the healthcare, and then reducing cost. Now we're moving to the triple C, which is compassionate, collaborative care. And that's where we involve patients as part of the healthcare team. We as healthcare providers are not fixers, but we're facilitators in the care. And then we think of the patient not as a victim, not as someone who's not empowered, but the expert patient. That the patient is the expert about their health and their body as well. So here's an example of a big idea. A pair of kidneys will never come to the physician for diagnosis or treatment. They will be contained within an anxious, fearful person, asking puzzle questions about an obscure future, weighed down by responsibilities, a job to be held, and bills to be paid. And so when we're looking at patient experience strategies, there are a number that have worked, and they're not related to technology. They're very simple things that were created by us as caregivers and supported by patients. The hourly rounding is one. Studies have shown they've improved scores by 13%. Medication education plan and discharge improves staff and patient experience scores. Noise reduction. Noise is a fundamental problem in healthcare because of the equipment that we use, constant vital sign checking, constant back and forth in and out of the room. And so when we created a culture of quiet, 19% of the scores were improved. Discharge conversation recording. This is so innovative. Will you actually record the discharge conversation that you have with the patient, that they can repeat, they can play it later on, so that again they can understand the information that was given, particularly about medication and other sort of follow-up instructions. And that increased patient experience scores by 56% in some organizations. And then of course, a lot of us do target training, but it's not customer service training. It's patient experience training. And this improved the likelihood to recommend, which is your net promoter score of 49%. And then leadership rounds, as we discussed. And so one of the ways that we train our caregivers is using the Communicate with the Heart program. And so this is a way we communicate to patients. We train the trainers, we train our caregivers, we have ongoing training. So the training is at induction, ongoing training, and then we measure by the demonstration of behaviors at the hospital level, at the employee level, at the patient level. And we even evaluate our expected behavior. So this is a caregiver evaluating themselves. Am I knowledgeable? Do I acknowledge visitors, welcome them? Do I take the complaints personally? Do I introduce myself when I first meet the patient? And so here you would rate it as what patients would say, what colleagues would say, and what visitors would say about that. And so while we talk about, oh, I'm nice to my patient, it's not just about being nice to your patient, it's about having empathetic communication. So empathy communication has reduced cost and improved health. And you can see the number of studies here in terms of diagnostic expenditures, end-of-life issues, readmissions, etc. And so remember that patients first. It's always patients first, regardless of your role. Whether you're a surgeon, whether you're a nurse, a pharmacist, a doctor. And so if it isn't patient-centered, it isn't care. And that's the philosophy. You know, patients may forget what we say, may forget what we did. They'll never forget the way we made them feel. And so I'd like to keep some time for questions. I'd like to conclude with a quick story. There was a farmer, in fact, this is a true African story. There was an African farmer who toiled his fields day after day just for a meager sum. And so a friend came by his house one day and said, "Why are you working so hard? People are finding diamonds all over South Africa. And so if you find the size of a diamond the size of your thumb, you could buy a town, a village. If you find one the size of the palm of your hand, you could buy an entire city." And so what the farmer did, he thought about his riches and he sold his farm just for a pittance and went off searching for diamonds. He searched and he searched day after day, desolate and derelict, eventually to diminish. But he sold his farm to the new farmer, and the new farmer was walking upon the farm one day with his horse, and let his horse take a drink in the stream that was flowing through the same farmland. And he noticed something shiny in the water. He picked it up, and it looked like a very pretty stone. And so he put the stone upon his mantel shelf. And a few days later, a man from the city came by to visit the farmer, and he noticed this big rock on his mantel shelf. And he exclaimed, "My goodness, that is the largest rock I've ever seen. That is a diamond." So the farmer said, "That's not a diamond, that's a pretty stone. And besides, there's hundreds of them in the stream flowing in the farm." And so little did the first farmer know that he was sitting on a field of diamonds, and yet he was looking outside to see the very riches which he had himself all along. And so, ladies and gentlemen, when it comes to patient experience, you're also sitting on a field of diamonds. The best resource you have are, in fact, the patients that continue for care day after day. So thank you very much for your time, and I'm happy to take questions.
Thank you so much, Dr. Devkaran, for this very engaging and very um, interactive and reflective webinar. We do have indeed a number of questions, so I suppose we should be starting with them. Just to advise, I don't think we will be able to address all of them, so Dr. Devkaran has agreed kindly to respond to them, and we will email answers to your questions on her behalf after the session. So it's not going to be straight away, but we will do it as soon as we possibly can. So the first question is from Ashbir Kidan from Ethiopia, and he's thanking you so much for this great presentation. And his question is as follows. Data on patient experience is of value to both users of health services and those aiming to improve the health system. Is it possible to know the recommended satisfaction percentage or rate? So he's just saying that he's from Ethiopia.
That's an excellent question. You know, when we're talking about when we're talking about satisfaction, everybody hits the goal for 100%. But patient experience is different. Patient experience talks about, you know, how often are you doing something? What was actually done during the care process? So you won't be able to get the particular benchmarks for the individual patient experience questions and domains. But what organizations do is that they have three particular areas where they can benchmark. The one is the likelihood to recommend. And we always, the higher the score, at least 90 and above. The other is the willingness to return. So are you willing to return to the organization should you need care? And then the other is your overall satisfaction, or how do you rate the organization overall? And so those things, in terms of the number, it should not be anything less than 8, and not nothing less than 8 is what I would say, 8 out of 10 for 80%. But most organizations are reaching the 95th or 90th percentile. I hope that
Thank you.
answers your question.
Thank you, Dr. Devkaran. The next question is from Marietta Kalu, and she's from Kingdom of Saudi Arabia. And she's looking to find out what recommendations can you give for a patient satisfaction survey. There is this encountered problem of language of collaboration between the healthcare provider and the patients.
So this seems to be a language barrier issue. Is that correct?
Yes. So what recommendations would you give when you're constructing the patient's patient satisfaction survey, where there is a definite problem, a language barrier between the healthcare provider and the patients?
So if you look at your patient demographic, you definitely need to look at the type of languages that your patients are, and then, as well as the educational level. So you may have different type of survey tools that you're looking at, different methods of measuring. So if you have a younger patient population that is predominantly English speaking, perhaps an application or web-based tool may be more appropriate. But if it's an older patient who speaks a different language and doesn't have much literacy in terms of reading, you may want to administer the survey with somebody supporting the patient. So you may ask a caregiver to actually do a survey interview. So apart from the common things like adding in the different languages, think about other methods of administering the survey. Depending on the age of the population, depending on the literacy level, and of course the ability of the patient to read. So again, thinking about interviews, thinking about either including them in focus groups as well, maybe engaging the family member to support you in the survey administration process.
Thank you, Dr. Devkaran. The next question is from Shashikant Pawar, and the question is as follows. What, in your experience, what is the ideal time to collect feedback from the patient? Is it post-discharge or during the admission?
So some of the literature has shown that the closer to the encounter you are, the better, the more accurate the information, and also the more positive the information is. That is because patients, after a while, when they leave the organization, they have something which we call recall bias. So they may not be giving you an accurate result. So in short, the best time is 24 to 48 hours after discharge. I've used the survey tool where we've administered just before discharge as well, and that has been very useful.
Thank you, Dr. Devkaran. The next question is from Rula Zahar from Lebanon, and her question is in connection to the email questionnaires. She's stressing that email questionnaires are not so successful because very few patients have emails. So what would you suggest in terms of how to administer the patient satisfaction survey post-discharge?
Yeah, so that's a very good question. Thank you, Rola. The methods that I use is the telephonic survey. So that's post-discharge that can be done. You can do a telephonic interview. The other mechanism is having an application where the patient could actually log into the application and actually record their perception of care there. The third is which is not really effective, but actually having the patient on their next follow-up visit record their experience of care that they had during their admission in the office setting. So you're still in the healthcare setting, but you're asking them about their experience in the previous encounter.
Thank you, Dr. Devkaran. The next question is from Douglas Funbush, and he's asking about a particular tool. So he's looking to find out your opinion on the Net Promoter Score as the point of care survey tool, if you're familiar with that.
I'm not familiar with that survey tool, but perhaps if you'd like to send me an email, we could look at it together. I'm happy to do that.
Perfect. Thank you so much. We will take 2 more questions since we started a bit later. So we will just take a question from Nayel, and his questions: do you prefer to conduct the survey by third party or internally? He's from Qatar.
Honestly, it doesn't matter. If you conduct it by a third party, the danger there is that they may not be refining it to your patient population. So you need to work with the vendor quite a bit to make sure that it's tailored to your patient population. If you do it internally, the bias is that the patient may perceive it as that it's not anonymous, or that it may impact upon their care. So you have to be cautious. If you do it internally, that tends to be my preference. Once you've refined your internal survey tool, then you can ask for a vendor to start managing the survey process, and that helps you with the data and analytics on the back end, and helping you with the survey administration. There are a few factors. One is, do you have a validated survey tool that you are confident is measuring your patient population accurately? Two is, do you have the resources to administer the survey tool internally? If you do not, then of course having a vendor would make most sense. So it really depends upon your patient population, depends on the resources that you have, and depends on the tool that you're going to use.
Thank you, Dr. Devkaran. And the last question for today is from Marco. He is thanking you for this fantastic presentation, and he is wondering to find out, how do you suggest to calculate the sample for the survey?
And so this is a very good question. You can use Sloan's formula, and I can send that to him via email. It's a simple tool about looking at what is your patient population size, and then taking statistical valid sample size out of that, depending on whether you're going to do a random selection or not. But in general, it tends to be 10 to 15% if you want a statistically valid sample size, but you have to have it randomized. If you cannot randomize it, then there are other mechanisms that you could use to select the sample.
Thank you, Dr.
And again, I'm happy to share.
Yes, if you can send the link to me, and we, by all means, will send it to Marco as well, and share with the remainder of the participants. I would like to thank you, Dr. Devkaran, on ISQua's behalf for this brilliant presentation, and for sharing your experience with our participants. It was indeed very useful, and I feel confident that after this session they would be able to understand patient satisfaction much better. So I would like again to thank you for sharing your experience with us, and also would like to thank our audience for joining us today and asking so many questions.
Thank you very much, Juliana. Thank you to the audience. Those were excellent questions, and as I said, I'll be happy to help respond through them via Juliana through email after the session. So thank you. I wish you the best in your patient experience journeys.
Thank you, Dr. Devkaran, and goodbye all.